Well, good afternoon, and thank you for joining us. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, welcome you to today's presentation entitled Framing HPV Immunization Education for Maximum Patient Acceptance, presented by Ms. Jane Cotter. Ms. Cotter is providing this course in cooperation with the University of North Texas, Texas Women's University, and MD Anderson in Houston. This course is part of a North Texas study examining HPV vaccination education among interprofessional healthcare providers. Working in conjunction with MD Anderson, UNT Health Science Center, Texas Women's University, and Texas A&M University, the Healthy Smiles Project's aim is to provide Texas dental hygienists with education to talk about HPV, oral cancer, and HPV vaccination as an interprofessional effort to increase vaccinations rates across the state. Dental providers may earn 1 hour of continuing dental education credit for submitting the completed online evaluation. I'm pleased to introduce you now to our presenter, Ms. Jane Cotter, Assistant Professor at TAMU Caruth School of Dental Hygiene. Ms. Cotter received her associate degree in dental hygiene from the University of Texas Health Science Center Dental School in Houston, a Bachelor of Science degree in dental hygiene from Texas Women's University, and a Master of Science degree in dental hygiene education from Texas A&M Health Science Center, Baylor College of Dentistry. Ms. Cotter is also a certified tobacco treatment specialist and has authored several professional articles, book chapters, and mentored student publications. So please help me welcome Ms. Jane Cotter.
Hi, everyone. Thank you so much. Let me see if I can get my slide up here. Okay, so you should be seeing, hopefully, the tiny URL, the little QR code for the pre-survey. You can go ahead and fill this out now as we begin our presentation. So today we're going to be talking about the HPV virus, the vaccine, and how to talk to patients about it. I'm going to play this little video.
I'm Sandy Wexler. I'm 62 years old currently, and I was diagnosed with squamous cell carcinoma back on July 2012. I went to the dentist for a routine checkup, and she did an external exam, and I had an enlarged lymph node, and went to the ENT doctor who biopsied, and it turned out to be squamous cell carcinoma, and referred right away over to MD Anderson Hospital. And I had radiation for 6 weeks and chemo for 7 weeks. And at that point, I believe it was about 3 or 4 weeks into my treatment that the surgeon mentioned HPV positive. And that's when I first learned that it was HPV positive, which was shocking. You never think it's going to happen to you. And it did. It was very difficult. I lost over 10% of my weight. And luckily, I did not need a feeding tube, but I had second-degree burns all through my neck. Pretty much survived on Boost the whole time. And all I can say is now that the HPV vaccine is available, I can't understand why a parent would not want their children to be vaccinated to avoid going through what I've gone through.
So we have a few of these little vignettes to play throughout the presentation, and they're available and free. So if you want to have them in your office and as a talking point, or as, you know, information that maybe you have a TV that plays in the waiting room, these are available for you to download. But you know, I like that she said that the dentist caught it which is great, in an extraoral exam. And also, you know, that the vaccine is there, and she could have prevented all of that treatment and disease process and you know, comorbidities that go along with being treated for oral cancer, just simply by having a vaccine. Let's see. There we go. This is my disclosure statement. I do not have any financial or non-financial affiliations with any of the entities, agencies, or products mentioned, and I am not an employee of or receive compensation from any pharmaceutical companies. Our objectives today is to have a clear understanding of HPV and its impact on patient health, identify and discuss the immunization process and safety with patients, and to be able to demonstrate effective patient counseling on HPV risk reduction and immunization. So first, I want to ask the question, what do you think? What are your vaccination beliefs? Do you consider this to be within our scope of practice to talk about vaccines? And what do you currently know about HPV, its role in oral cancer, and its safety, the vaccine and its safety? So you just saw a bunch of celebrities there that have had HPV related cancer, not all oral cancer. Some of them were in other areas. And, you know, it's great when a celebrity gets it, because they can bring a lot of knowledge and a lot of exposure to the topic, but we want to be advocates ourselves. So I'm going to be addressing this subject in three processes. So we're going to have education, and then we're going to talk about counseling techniques, and then opportunities during your appointment to start this subject, to broach the subject. So step one, we're going to talk about the education. So why dentistry? Why do we need to be talking about this? Well, the CDC, the WHO, the American Cancer Society, the ADA, the American Pediatric Dental Association, and the Dental Hygiene Association, American Dental Hygiene Association, all agree and have statements that this is something we need to be talking about to our patients. Oral cancer is dentistry's cancer. And so we need to address any kind of risk reduction that we can for oral cancer. And this vaccine and this virus plays a big role in oral cancer. A little bit about the vaccine, or excuse me, the virus itself. It's limited to humans. It has over 200 genotypes. So the ones that cause the warts on your feet are different from the ones that cause the wart in the genital area or the oral environment. There's a ton of them out there. Basically, they live in the body's epithelial cells and cutaneous and mucosal tissue epithelium. They can survive outside of the body on inanimate objects, but because there's so many different genotypes, the precise survival time is unknown. The virus, some strains of the virus are resistant to heat and drying, which is our typical sterilization process. Most are sensitive to UV irradiation and chemical disinfection. So the virus is spread mucosally via skin-to-skin contact. I used to think when I was a kid that if you picked up a frog and the frog peed on you, then you would get a wart from the frog. I thought that warts came from frogs, but it's spread skin-to-skin contact. Less commonly, they can be transmitted through vertically through the cervical canal during delivery, or later from the mother to child, or what's called horizontal transmission via fomites or fingers. So if you have genital HPV and your fingers are there, and then your fingers go in your mouth, you can transmit it from one area to another via those transmission methods. And this is how they kind of discovered that some of these ways of transmission, or some of these viruses, actually survive outside of the body, and they're on gynecological tools, which is a problem. You don't want to spread that around in a gynecologist's office. The pathology, currently 80 million people, just in the United States, 80 million people are HPV positive, and there's 14 million that become infected each year. Post-inoculation, some will clear it on their own within 2 years, but reinfection is possible. Some become infected and don't show any symptoms, and they just have the virus living there in the tissues. And some develop warts, pre-malignant lesions, and some may develop cancer. Typically, genital warts will develop within 3 months of exposure. And HPV type 16 and 18 account for almost 70% of oropharyngeal cancers and cervical cancers. So there it is again. HPV is detected in 70% of oropharyngeal cancers, and the incidence is increasing. It has outpaced tobacco and alcohol use as a causative agent for oral cancer, and especially oropharyngeal cancer. And by this was a study done a while ago, but by 2020, the incidence is to exceed cervical cancer by 2020, and it already has. Yeah, so oropharyngeal cancer, there are high-risk strains, specifically 16 and 18, but any of these other 9 strains are can cause oropharyngeal cancer. So you can see here, by 2016, the oropharyngeal cancer, HPV-related oropharyngeal cancer, has outpaced cervical cancer. So we've already gotten there before 2020. So this is a really big problem. I mean, this is something that we need to address, and certainly something that we need to be talking to our patients about. Not only just to prevent cancer in all of these different areas, but especially in that oropharynx. The sites for oropharyngeal cancer are most commonly found in the oropharynx. So cancers that are found from the hard palate forward are typically more related to genetic predisposition, or tobacco use, or alcohol use, drug use, those kind of things. The ones that happen back here in the oropharynx are most commonly going to be HPV related. And you can see how far back this area is on the anatomy. I know that in my experience, I've had patients in my chair that have an active lesion. It hadn't been removed yet. It had already been diagnosed. They were scoped at the ENT, and they found, you know, this lump or tumor, and I wanted to see it. So I'm yanking their tongue out, and I'm shoving my mirror back there and trying to get an eyeball on it, and I could not see it. Although I could palpate the outside and feel the lymph nodes. A lot of times that's how this is diagnosed, is extraorally. Let's listen here to this. Come on.
My name is Rob Joyce. I'm 61. I'm from here in Houston. I was diagnosed with squamous cell cancer, base of the tongue, stage 3 HPV related. I felt some shame and embarrassment to say it at first. Treatment was radiation and chemo-based, platinum-based chemo, at 30 daily treatments, radiation treatments, and 1 weekly chemo therapy during that same time frame, 60 chemo. It was very difficult as the radiation took its rash and harm on me very quickly. At about treatment 25, I was begging my radiation oncologist to stop, and that I didn't want to go any further. It was starting to affect the way I spoke, the way I ate. If I drank, I lost a considerable amount of weight. So it was difficult for me. Looking back at it, being able to get the HPV vaccination that would have assisted me or prevented me from getting this squamous cell cancer. I think it's wonderful that MD Anderson is promoting the HPV vaccination and the research that's necessary to eradicate this HPV cancer.
So that one really strikes home because nobody should feel ashamed of getting cancer, no matter how they got their cancer. That just kind of rubs me the wrong way that he felt ashamed that he had it because it's a sexually transmitted disease. And that's something that we really need to address when we're educating, that, you know, no matter how you got it, it doesn't matter. We just need to eliminate the ability to get it by getting a vaccine. We want to talk to our patients about the signs and symptoms of oropharyngeal cancer. So symptoms, common symptoms are going to be that persistent sore throat, the pain and difficulty with swallowing, some unexplained weight loss, voice changes, ear pain, a lump in the throat or feeling like there's something back there, making it difficult to get the food down, a lump in the neck, or in a large lymph node. So these are questions that we can ask of our patients while we're doing our oral cancer screening or just prior to doing the oral cancer screening, that will tell us a little bit more about what's going on in that oral pharynx, because you're not going to be able to see the base of the tongue or, you know, below the tonsils. I mean, sometimes you can't even see the tonsils. Patients will close up the back of their throat because they don't want to have to swallow or anything. So our emphasis of prevention should be letting the patients know of these specific symptoms, and then the things that they can do to decrease their risk, reducing or eliminating alcohol, reducing or eliminating tobacco, and then reducing the risk for HPV infection, whether that's from using the vaccine or safe sex practices. So what about the vaccine? What do we know about the vaccine? Well, it is not a live virus, but they're virus-like particles. So it's very similar to the COVID vaccine. There's no viral DNA. They take a single viral protein and they grow it, and this is what makes up the vaccine. And this protein, this viral protein, induces the production of the protective antibodies in the body, so that you get that protection. The Gardasil 9 is currently the only HPV vaccine available in the United States. This specific Gardasil 9 is indicated for males and females 9 to age 26. It can be given up to the age of 45. However, you kind of have to look at what is going on with the patient. They probably have already been exposed to the HPV virus. They may have it already So are they in a high risk group? Immunosuppression, multiple sexual partners, different kind of things. So that's a different kind of discussion, but it can be given up to age 45. Now, I always get asked if you already have been diagnosed with genital warts, then if you get the vaccine, does it help you get rid of it? No, it does not. It is a preventative or prophylactic vaccine. So it's not going to help you get over, which is why we want to get it into the children as young as possible. Another question I get commonly is why so young? Well, many of you know that the hepatitis B vaccine is given at birth now to prevent hepatitis B. They give them this because it's a common virus that can be obtained, or not obtained, but can be caught by humans, and it causes liver cancer. It causes problems with the liver, right? So if we can give a vaccine to prevent that, why not do it? This particular vaccine, the uptake of the viral protein and the creation of those antibodies is at its highest between 9 and 26. So that's why they give it at that specific time. This vaccine will prevent 9 different strains of the virus. You can see them listed here: 6, 11, 16, 18, 31, 33, 45, 52, and 58. So 7 of those are can cause precancerous, dysplastic, or cancer. And 2 of those are more with the genital warts, but they all make a wart. It's just whether or not they are really cancerous or not, or precursors to cancers. The dosing schedule for routine vaccination, we usually start around age 11 to 12, but it can be started as early as 9. And they will receive 2 vaccines, the initial and then one within 6 to 12 months after that initial. If they don't get their vaccine until age 13 or later to 26, then they will require 3 vaccines, one at the initial, the second one 1 to 2 months after, and then after that 6 months after, to be fully vaccinated. The adults 27 through 45, whether they were not adequately, they only got 1 dose of the vaccine when they were a child, they didn't get any of the follow-up vaccines. That's a decision that you can make with your healthcare provider, whether or not that would be advantageous for you to do. And you would follow up with 2 more of the vaccine injections. So talking about vaccine safety, this vaccine has been studied rigorously since its introduction, well, before its introduction, and then since 2006, when it was introduced, there have been over 160 studies done about safety in humans for this vaccine, and they have all shown a favorable safety profile. Gardasil 9, or Gardasil, excuse me, Cervix 4, Gardasil 4, and Gardasil 9 are the 3 that have been tested, and 135 million HPV vaccines have been administered so far and have shown a consistent safety and effectiveness profile. The protection also remains high over time, meaning that we don't require boosters for this vaccine. And in fact, they're doing studies now to maybe see if maybe we don't need to have these follow-up doses. Maybe just one, it's just a one and done shot we can do with our vaccine, with the HPV vaccine. Those are current studies that are being done. We don't have any data on that just yet. So how do we know that these are safe? All vaccines are monitored by these 3 different agencies that work in conjunction with the CDC and the AMA. Adverse events are reported to these agencies, and these agencies investigate these events to determine if these events were directly caused by receiving the vaccine. So anytime somebody comes in with some sort of adverse event, whether it's an allergic reaction or chronic fatigue or something else, they look back in the health history of the patient, and they're always asking, you know, have you changed anything? Have you received any vaccines recently? Blah, blah, blah. And if they had, then they get reported to these agencies, and these agencies go in and see, was it because they got the vaccine that this adverse event happened? Common side effects of the vaccine are the same as with any other vaccine: pain and redness at the injection site, fever, headache, nausea, muscle pain, and syncope. So just like with the COVID vaccine that we're all pretty familiar with, you had to go and sit in a holding area for 10 or 15 minutes with a nurse supervising you after you received the injection to make sure you weren't gonna pass out or have an adverse reaction. It's the same protocol with the HPV vaccine. You just go and sit, and if you don't have an adverse reaction, then you're good to go. They have looked into adverse events that have been reported, such as chronic fatigue syndrome, loss of fertility, primary ovarian insufficiency, and death. And there hasn't been no increased risk identified or evidence to support a causal link, and no verified reports of death that the vaccine was responsible for the death of the person. Pregnancy, of course, vaccine is not recommended for pregnant women. However, if you receive the vaccine and find out later that you are pregnant, of course, you're not going to get the follow-up vaccines until after delivery of the child, but it's not considered a risk for the pregnancy that you have received the vaccine. So who shouldn't get this vaccine? So anyone who has a life-threatening allergy to any component of the vaccine. Remember when we were talking about how the vaccine is made, they have those virus-like particles, these little viral proteins that they grow in a yeast medium, specifically the Saccharomyces cerevisiae, or baker's yeast. And so if you have an allergy to baker's yeast, then you should not take this vaccine. You should counsel your patient to employ other methods of HPV prevention, such as protected sex or limited sex or no sex, whatever. I often get the question of, will this vaccine cause, does it cause problems with gluten allergies or sensitivities? And no, it does not. It's not related to that kind of sensitivity. It's only related to this particular yeast. The vaccine is not recommended for pregnant women. And if you're sick or moderately ill, moderately or severely ill, you should wait to receive the vaccine until you recover, which is similar to all vaccines. How much does it cost? Well, this is an expensive vaccine, but Medicaid and private health insurance cover the vaccine. If you have to pay for it out of pocket, there are out of pocket coupons that are available from Merck. There are places where you can get it for free. The Vaccine for Children program, CHIP, immunization grant program, and Merck Assistant program. Some health fairs will distribute the vaccine for free. So it's very easy to get this vaccine and not have to worry about cost being a deterrent. It's available everywhere. Medical providers, in some states, dentists can even give the vaccine. Of course, the Vaccine for Children program, those providers there, which are typically doctors or nurses, pharmacies, local health departments, college health clinics, and schools. So there's a myriad of options for you to choose from where to get the vaccine. And if they don't have it available, like, you know, at your local pharmacy, they can always order it and, you know, get it in, and then you can go and get your vaccine. So let's talk about efficacy. So this study was conducted, this survey was conducted in 2021, and it shows that a lot of the states have 70 to 80% coverage. That's about 17 states, I think, in all. But here in Texas, we're at the bottom. We're down here at 37 to 56, so barely 50% of adolescents ages 13 through 17 have received an up-to-date vaccination, meaning that they've gotten the initial dose and the follow-up doses. So we have some work to do here in Texas to get this vaccine uptake increased. The vaccine also shows very good efficacy. Once they studied, the vaccine was introduced in 2006. We can see that, especially by 2007 and through 2010, we have a big decline in the prevalence of HPV infections. So this is just looking for genital warts, and this is only in women. This study was only done on women, teenage girls and young women since the introduction of the vaccine. So if we see this huge decline in the prevalence of these HPV infections, which is great, because that's showing that this vaccine is working for us. It's effective in preventing HPV infections. The HPV vaccines are prophylactic and highly immunogenic, meaning that the uptake of the antibodies or the activation of those specific antibodies to fight the HPV infection is almost 100%. It is taken up very quickly. That's why, again, they're doing these studies to see maybe they just need to do one injection and they don't have to do the series. There's a minimal decline in the antibody response over time, meaning that you don't have to get boosters. You don't have to go in for yearly boosters or bi-yearly or every 10 years, whatever. A study done in 2017 by the CDC looked at vaccinated groups against unvaccinated groups, and both groups showed a decline in HPV infection, the anogenital warts, and cervical precancers, which suggests that we can get a protective herd immunity if enough people get vaccinated. But we need to continue that vaccine on everyone as the children come along. We need to continue to immunize the children so that we can eliminate this risk. So step 2, we're going to talk about the motivational interviewing and counseling techniques. So when we talk about this, we want to talk about the importance of the vaccine. We want to normalize feelings of concern and understand that the patient has autonomy on whether or not they are going to vaccinate themselves or their children. We need to ask permission to discuss if it's something they want to discuss and address those concerns in an empathetic manner. The change is determined by the client, not the clinician. And so we want to have a collaborative effect or relationship with our patients rather than an authoritative. You can ask open-ended questions, ask about their current knowledge. Do you know about this vaccine? Do you have any kind of questions? There's some examples here that you can read to see where they are in their area of change, whether or not they are going to change their behavior or accept your the vaccine. Reflecting or repeating or paraphrasing is a good way to communicate with your patient to make sure that the patient is understanding what you're saying, and it's kind of plays that role of turn taking in a conversation so that you can expose maybe some of those underlying feelings of resistance. So common reasons why parents do not vaccinate their children is they have a lack of knowledge or misinformation. There's a lot of information out on the internet, and we know that not all information is reliable. So we want to make sure that we're giving them evidence-based information. They have concerns about whether or not it's going to make them have sex earlier. I don't know about you, but anytime I went to go get a vaccine, I never knew what vaccine I was getting. I just knew that if I didn't cry, then we got to go to McDonald's. That's the only thing I really knew about it. So I don't understand why somebody would worry that their child is suddenly going to go have sex because they got a vaccine, unless they were told, I guess. Moral and religious concerns, and my kid's not having sex, so they don't need to do it. There's concerns around safety, effectiveness, and cost, and it depends on the physician's or the recommender's attitude about the vaccine. That plays a big role. So here's another, you probably may have seen this commercial. I can get it to load here. It's the Did You Know commercial. We're kind of running low on time, so I'm just gonna bypass that one. But parents do trust providers and need information to make timely decisions. This vaccine was introduced as only for females, only for cervical cancers. And if it's on the cervix, of course, we're getting it via sexual contact. And so that makes it difficult for especially dental health care providers to talk about. So I'm suggesting and recommending that we just talk about it in relationship to oropharyngeal cancer. Let's see. So you want to be direct. You want to know immunization and vaccine concerns, and be prepared to answer questions. Try to desexualize it. We don't need to bring up the transmission, how it's transmitted. We just need to talk about what happens when we get it and how that can contribute to a higher risk for oropharyngeal cancer. Mothers typically are immunization decision makers, so we're typically talking to mothers about this. Not that you can't talk to the fathers about it. Put it in context with the other vaccines, like the hepatitis B vaccine. That's a sexually transmitted disease, and they're still vaccinated for it. This is an oral cancer prevention. This is a prevention of cancer. Mic dropped. I mean, who doesn't want that? if just listening to some of these patients, you can see how devastating oral pharyngeal cancer is. Cancer anywhere in your body, it's devastating, but in our area, it's particularly devastating. You want to have supportive materials and brochures and information sheets available to your patients, and sometimes that can even spark the conversation. So we have successful counseling tips here. Just having that strong relationship with your patient and appreciating the impact of the vaccine. This vaccine will prevent cancer or reduce your risk. No, it prevents cancer. And your recommendation is the #1 reason why people go ahead and get a vaccine. If they get that recommendation from you and you have that strong patient clinician relationship, they trust you and they will go ahead and get the vaccine. So step 3, how do we start this conversation? We can start it during the health history. We can ask about vaccination. We can ask them if they know about HPV or the vaccine. We can tell the patient during the oral cancer screening that we're performing the screening and teach them the most common signs and symptoms for the HPV related oral pharyngeal cancer. And then we can have pamphlets or signs about oral cancer in the office so that the patients, if they're interested or looking at it, we don't want to just talk to patients that have children. We want to talk to all patients, because even if they don't have children, maybe they have young people in their lives, or they have nieces and nephews, or maybe they're going to have kids in a couple of years. So this is something that we need to talk to all patients about. April is Oral Cancer Awareness Month, so that's a great time to bring up this conversation about talking about oral cancer. And your recommendation is the strongest motivator. You can use storytelling techniques to connect with your patients. This kind of gives a sense of making a sense of a health journey. Here's an example here. Last year, I had a patient who came in for a checkup, and I discovered a lump in his throat, and we talked about his behaviors and lifestyle choices. He didn't know that smoking and drinking and even having oral sex puts you at risk for mouth and throat cancer. No one had talked to him about the human papilloma virus or the vaccine. And what do you know about it? And so, using example, we do this all the time in patient education. Oh, I had a patient once. Oh, I had a patient once. To normalize those feelings that the patient may have, or concerns that the patient may have, that, they don't want to be the one who, oh my gosh, I'm the one who got oral cancer from the HPV because I had sex with somebody. It kind of normalizes it and brings it more into, takes the shame away. The CDC has these different scenarios. When the patient asks this, here is a good answer that you can give. Of course, you want to tailor it to your specific way of educating the patient. But this is just some examples here. If you have no idea how to talk about it, here are some good examples, and these are available to you on the CDC website. Do we know it's safe? What are the side effects? Again, these talking points here. Can it cause infertility? No, it doesn't. But cervical cancer does. So getting the vaccine is important. How safe is it? Is it going to give them the green light to go and have sex? So now that we're at the end here, did you think about it? Do you think that it is something that we as dental health care providers are responsible for, that we can assist patients in their decision-making process? We play a role in diagnosing HPV cancer, HPV related oral cancer. Why not talk about preventing it? Immunization counseling is a skill for the future. And we need to, as a group, if you're working in a private practice, everybody in the private practice needs to have the same message. If they're not comfortable talking about it, well, then, okay, I'm going to bring in my hygienist and she's going to talk about it. Or I'm going to bring in the assistant and they're going to talk about it. However it gets through to the patient. But a consistent, consolidated message is important. So our key takeaways are going to be that oral cancer is dentistry's cancer. Rarely is cancer preventable. However, this one is oropharyngeal cancer, HPV-related oropharyngeal cancer is preventable, and it's via this vaccine that it is preventable. Your patients value your expertise, and missed opportunities to educate your patients about HPV-related oropharyngeal cancer and the risk reduction for this disease can result in morbidity and mortality. I really like this one, so I'm going to play this one, hopefully 24 minutes.
My name is Eric Statler. I am a 9-year stage 4 metastatic oral cancer survivor. Head and neck and oral cancers are historically difficult to detect. Survival rates in head and neck cancer are really low. So early detection and prevention is imperative.
Oral cancer is a particularly dangerous type of cancer because by the time it's detected, most of the time it's already metastasized. It is painless to begin with, and it comes in many forms, and that makes it very, very difficult to diagnose. Dentists see patients on a regular basis, see much as 2 or 3 times a year. And I have a personal policy of screening each and every time I see a patient. It doesn't take that long, but it may save their life.
So when you're talking about screening for HPV-related head and neck cancers, your dentists are imperative. They're the most educated about the disease, and they see 83% of our population before the age of 17.
UGD's particular work on preventing oral cancers through work through the oral examination process that happens in a dental office, and combine that message with getting your kids vaccinated to prevent HPV-related oral cancers.
Oral cancer specifically, or tobacco, alcohol, and HPV. HPV, when you look at the numbers, it's the fastest growing demographic, the fastest cause of head and neck cancers and oral cancers.
There's a commonality and a shared goal of wanting to prevent a very serious form of cancer. In this particular case, it's oral cancer caused by the HPV virus.
The message that we're trying to get out to the patients is that the vaccine exists. If I were to ask you if there was a vaccine to prevent cancer, would you be vaccinated? And I think the majority of people would say, yeah. Well, guess what? There is a vaccine against HPV-related illnesses.
Kids of the age range of 11 to 13 are in the dental chair a lot more often in some cases than they are in a pediatric office. So we look and view the relationships that we have with dentists as being a key strategic partner in the message and the advocacy about wanting to get kids vaccinated. And we view a strong recommendation by a dental provider as important as a recommendation from a doctor or a pediatrician to get children vaccinated.
And the reason why it makes sense for all of us, including dentists and doctors, to work together to promote this is we all have access to young kids in our practices. We do as otolaryngologists, dentists do, pediatricians do, primary care doctors do. So we should all be working together to push this. And if we can prevent people from suffering through the treatments and the difficulties associated with this by simply getting them vaccinated, it's well worth our efforts to work together towards this goal.
And if you can prevent pain by a vaccine, that makes sense to me. It gives you hope. And in cancer care, hope is sometimes what gets you through.
Yeah, so oral cancer is dentistry's cancer. So we need to address it and prevent it as we can by talking about HPV and talking about vaccination, especially here in Texas. So I talked about having resources in your office available for patients to spark conversations or just to get evidence-based good information. These are available from cdc.org. So if you just go to that website and put HPV in the box, all of this stuff will come up and you can choose and you can get it from them. You can download it yourself, or you can ask for copies from the CDC, the American Cancer Association, the Oral Cancer .org and immunize.org also has free information that you can have in your waiting room. And I would like to take this opportunity right now to thank the Texas Oral Health Coalition for this opportunity to discuss this very important subject and for your kind attention. So thank you. I have here, this is the QRL for the QR for the host survey. So if you want to either go to this URL, I think Dr. Greiner can drop that into the chat box if you're not able to take a picture of the QR code. And if you would be so kind as to fill this out for us, we would really appreciate your input in our study. And I would like to invite any kind of questions that anybody has. Let me see if I can look. Is there a test for men? No, there's really no test that will that you can give to a man or a woman for HPV. The only way that you would know is if you visually saw it, or like in a pap smear where you're scraping the tissue off. Those are the only ways you would know if HPV is present in the body. You would have to find the spot and then do a biopsy of it. So anytime you have a lesion in the mouth that is a papilloma, or regardless of where it is, you would want to remove that and then send it for testing. Once the wart is there, then the person has already been exposed. So there's really no reason to vaccinate that person, but we can educate them and they, can hopefully influence the people around them to get the vaccine. Let's see. Oh,
while you're looking at the chat box, Jane, are there any questions? If anybody would like to ask their question verbally, we can unmute you. You can unmute yourself. We just don't want everybody talking at the same time, okay? So you can go under reactions and raise your hand, and then she can call on you to ask your question verbally if you'd like.
Can I see the people?
I'm not seeing anyone right now. I had a couple of questions. So this was so good. And I saw Matt Jacobs' comments in the chat box. This was really a very informative, comprehensive presentation today, Jane. Thank you so much for being here. I was really shocked by the percentages of at the beginning when you showed the 16% in the 80s, and now we're over 70% and still climbing. I thought that was really shocking. And I also wanted to ask, because one of those early slides you had put down that the virus, some viruses are still heat resistant. Are we talking about the HPV virus? I mean,
Right, yeah.
They still work to kill it?
Yes, that's, that was the focus of that study, was to see which specific, you have to know what kind of strain of HPV virus that you have to know how to kill it. Most all of them were affected by heat and the heat. Most all of them were affected by the UV radiation, but then those chemical concoctions that we had at the bottom, the hypochloride, the glutaraldehyde, all of those will help kill the virus on inanimate objects. But just knowing that it can live outside of the body, we don't know how long, but it is a problem. We need to look into a little bit more about how can we kill it. But yes, the autoclave will kill it.
Okay, good to know. But cold sterile doesn't work as well. Okay, and they don't even use that anymore, I don't think. Any other questions? What was that? Question in the chat box, she said. Is it a process to be able to implement this topic in a dental hygiene school? Permissions? Oh my goodness, yes. Let's see.
Yes, absolutely. Actually, this has, I already implemented this educational module into my course at Texas A&M. We have presented this course at TWU in their dental hygiene program. Certainly educating new providers about this, but then also clinicians who are already out in practice. So yes, the permissions, I don't know that we would need permission from, I didn't ask for permission, I just did it. But yeah, this is something that we talk about as far in our program and at TWU. So does that answer your question? I don't know about permissions.
I want to challenge everyone that is on this webinar today to please, because again, another shocking was the low score, the low percentage that we had in Texas that our children are not getting vaccinated. This is really disturbing. This is, we need to get that increased. So as a dental hygienist, if you've ever found HPV in a patient, you know how necessary this is, and early prevention works. So let's try to see what we can do and get as many people vaccinated as we can, and to spread the word. I again want to thank our presenter, Ms. Jane Cotter, almost maybe a doctor, but thank you so much for this information. And I want to thank Dr. Greiner and Allie also from the project, from the Healthy Smiles Project, for being in attendance and providing this opportunity to share this important information with you all. So thank you again for your time.
Hi, thank you very much.
Okay, thank you.